was to be presented by Galina Shapiro. She is brilliant MD, PhD, but she is in the army now and couldn't come this weekend to present it. We all know that to have successful hemiepiphysiodesis, we need to have adequate remain growth potential. Historically, stapling was the first technique for temporary hemiepiphysiodesis. Later on, tension bend plates and percutaneous screws were used, and they have been shown to be equally effective. However, there is not much data comparing directly the screws and plates. Nowadays, tension bend plates really widely used technique, and we suggested that hemiepiphysiodesis using the screws crossing the growth plate would be as effective as plates for guided correction of the varus of valgus deformities, both in primary and secondary etiologies. We retrospectively collected the cases done starting the 11 till the end of 16. We found 35 patients, 55 growth plates divided to two groups, tension bend plates, 14 patients, screws, 21 patients, and it was a bag of varus and valgus deformities. A follow-up was to either skeletal maturity or hardware removal or any other orthopedic procedure, and the average was 15 months follow-up. The technique was described by Meta Zhou. He used actually both cross screws or screws going parallel to the condyle. Those going just on the side of the condyle are technically much more challenging. In that publication, he also described not just epiphysiodesis, but hemiepiphysiodesis. He also mentioned in that publication that removal of the screws for hemiepiphysiodesis did not cause any bone breach. The technique is actually very easy. You aim toward the mid-size of a hemi-plateau or hemi-condyle, and on the lateral it should be in the middle. That way you have enough purchase with a screw. It should be at least 4 threads beyond the growth plate, and then it will have enough grip to hold it and enough strength for growth plate to keep growing. We had 14 patients in the plate and 21 for the PETS group. We had predominantly valgus deformity, different etiologies. Weight was not significantly different. However, we have trend that those guys with the screws were much higher weight. What we found that screws surgery is shorter. However, the removal was longer compared to the plates. The most interesting finding was that PETS was much faster potential to correct the deformity. And if you break it down to the varus of valgus, when you measure when you deal with the femur, both with varus and valgus, it was faster with the screws. For tibia, for the tibia vara, plates and screws had the same speed of correction. Just present a case of a kid, 12 years old, Rubinstein-Taube syndrome, severe valgus deformity. We used also arthrogram to see that we're not really penetrating with that really deformed condyles, and had excellent correction during the year. And when we removed the screws, the deformity did not recur, and we had not noticed any physeal bar. The other kid, even younger, the youngest actually we did, she's 9, she had very weird multiple X karyotype syndrome. And again, To correct the big deformity, screws used, good correction, and that definitely not necessary any osteotomy to perform. Complication rate was pretty similar in both groups. It was mostly incision related or some hardware failure or breaking up the screws. No breaking screws in the screws group. The drawback of the study, definitely it's retrospective. We have relatively small number and the deformities are mixed. Our study actually echoes Park report in 2016. They have very similar results in terms of correction of valgus deformity. They analyzed only valgus deformities. We had faster correction with screws for also for the severe deformities. To put the screws in, it's minimal incision. You stay away from the joint. It's relatively short surgery. You can correct both varus and valgus deformity. It also works well for sick physis. Even they have a slow correction, but you may have bigger deformities. We didn't find any significant difference in the complication rate. No physeal breach with those who had their screws removal. No premature growth arrest. And our protocol, we can conclude that screw surgery is safe and have quick correction. In our protocol nowadays, that we use it for adolescent, we use it for those with relatively limited growth potential when you need quick correction, and we use it for big deformities. That way you may reduce the need for osteotomies or number of osteotomies. Thank you.